An event like tonight really provides a wonderful opportunity for NeuRA to engage with its community, to engage with our supporters and also people affected by the diseases in which we're trying to find cures and better management plans. It gives us a chance to roll out the new strategy, which is really maintaining healthy brain function throughout the lifespan. And who better to really introduce that than Professor Michelle Farah, who's a paediatric neurologist employed through the Sydney Children's Hospital Network, but undertaking her research here at Neuroscience Research Australia. We've come up with a new strategy, so it's called NeuRA Forward, and it's really got three main themes. And the first one is preserving brain function across the lifespan. And so while we've traditionally looked at healthy brain aging and the problems of neurological disease and in mental health as people get older, we hadn't really focused on preconception, in utero, neonatal experiences, childhood development. And that's been a missing gap in NeuRA. So we're going to obviously expand on that tonight, but part of that has been we've been able to recruit a real gun in Michelle Farah, Professor of Pediatric Neurology, based at the Sydney Children's Hospital, employed through the University of New South Wales with her research program here at Neuroscience Research Australia. And she can take the problems from the clinic here to a research program, come up with an understanding of the disease causes and new treatments, focused treatments, which we're going to hear about, and then bring that back into the clinic to improve outcomes for children with these neurodegenerative and dementia conditions. And whilst traditionally a lot of these children would die in their infancy, 3, 6, 9 months, they are now having normal lifespan well into their 9, 10 years old. That's when the treatments first started, and we're going to hear from Lakira later on about her experiences as a mother. The second theme of our new strategy is maximising brain function. So that means bringing in all of the therapies, and these therapies aren't just medications, they're also physical interventions, helping people to avoid falls, coordination, looking at the effects of injury and minimising any long-term brain effects. The third part of the mission for NeuRA is diagnostics. And I think we're going to touch on that with Michelle, but it's really, the field of medicine is transforming through technology. And it's really amazing now that we can do the full sequencing of an individual, quickly work out what the problem is, come up with a focused treatment for an N=1 approach, and alter the whole trajectory of someone's life. And that's moving more and more into clinical medicine. So it really is an exciting period, and we really welcome your, I suppose, commitment in the horrible weather. But I think we're going to hear some amazing updates and really an introduction to pediatric neurodegenerative disease. And so I'd like to firstly introduce Michelle Farah. Michelle is a paediatric neurologist, did her PhD in trying to understand neurodegeneration in children when there was no therapy available, has appointments, as I mentioned, in the Sydney Children's Hospital, is employed by the University of New South Wales and now NeuRA. And we're also very fortunate to have Lakira, who's a mother of Kalani, who has a diagnosis of spinal muscular atrophy. And so maybe I can ask you to come up to the stage, but thank you. So perhaps we could start with you, Michelle, and you can tell us what exactly is a paediatric neurologist, and just tell us roughly about your day-to-day life.
Thanks. Good evening, everyone. I'm probably the person you don't want to see professionally, because usually it means that there's something wrong with your child or someone you love's brain, and that's always a very scary thing. Yeah, a paediatric neurologist is someone that deals with brain problems or nerve problems or muscle problems in children. So some of the conditions that we see would be epilepsy, cerebral palsy, muscular dystrophy, but there's over probably 4,000 individual conditions that we see. A lot of them are difficult to treat and have a huge impact on the child, but also their whole family, their school, their life, society.
And so perhaps you could give us some sort of historical journey through spinal muscular atrophy as an example of something that was completely untreatable through to today.
Sure. So when I was training in pediatric neurology, we'd be asked to see a baby, often in the intensive care unit, who was floppy and having trouble breathing. And actually the very first baby I saw as a brand new neurologist was such a baby. He'd been carried around on his pillow for a few months because he couldn't move his arms or legs, and that was the only way his parents could hold him. And they thought he had a cold, and he was flown in by ambulance and put on a ventilator, at which point we met him and said, my heart just sank. I knew what he had. He had a motor neuron disease affecting a baby. And everyone here will say that doesn't exist. And it didn't exist because these children never survived. The average survival was 9 months. And so it wasn't visible in society. In fact, it was the leading genetic cause of infant death. And I think when I was finishing my training, one of my mentors said, I've just been to a conference and there's some really interesting things happening, but no one in Australia is researching this condition. We need to. So that formed a partnership with Matthew, and really getting ready for therapies and having clinical trial readiness is really important. So we gathered the cohort of children, described their survival patterns, and developed new tools on how to measure what was happening, so that if there was a therapy, we could show it was going to work or not. And at the end of my PhD, I got an email from a company called ISIS Pharmaceuticals. And so we said, yes, we want to help with this new treatment. And that treatment was a randomised, so you flipped a coin, and either the baby got the experimental drug or they got a sugar injection. And so we participated in that, and the first baby we enrolled in that study got the sugar tablet or the sugar injection in their spinal cord, and then the second baby got something else, and it was immediately obvious this was working, because the day you diagnosed spinal muscular atrophy was the best day you would ever see that child. It was downhill. There was loss. And that baby came in one day and was holding its head up and eating a twisty. And these babies couldn't swallow. They choked on their food. They needed tubes, as the condition advanced. And I went to Margot, who's in the room, that drug works. And she goes, I can't tell you. You're not allowed to know. And it was really obvious, and it was so exciting to be able to see that change. And that girl's now 10. And it's a very special time this year because it's the 10th anniversary of the very first treatment. And Kalani was one of the very first children in Australia. And what actually happened was there was a petition saying, you can't keep going, this is unethical. The Pope signed it. And so the company announced that they were stopping the study because it was working. That doesn't happen very often. And the announcement was to the US Stock Exchange. But it meant that we could immediately start offering the drug on compassionate access before it was approved to all our children, and Kalani was one of those children that benefited from that. But I think as a neurologist, I think I do my job because of hope, and it's always to say, what can we do better? And as you would know, a motor neuron disease, they're non-dividing cells. You have to treat them early. And I thought, let's do better. And so I kept nagging newborn screening, going, we could diagnose this at birth and we could save those motor neurons before they disappear. Because you'll lose 50% of them before you get symptoms, and then you'll lose probably 90% before you find a neurologist. So we were probably the third place in the world to start newborn screening for spinal muscular atrophy. And what we did was we were also developing new treatments, including gene therapies, as we did that. And I think that was really important because we had research embedded in what we were doing. We were doing this because we wanted to treat patients, but we wanted to show that other people should do the same. So everything we did, we were collecting the data. Patients were very generous, saying, yes, please help. We want other people to help. we wrote lots of papers. And what that meant was we were then able to say, we're not going to stop this. And in fact, now every baby in Australia who is born has a heel prick and is tested. And that's been over 1 million babies since we started.
It's a remarkable story. When Michelle does this at a neurology conference, a lot of the neurologists start crying because they haven't, gone from a treatment to these terrible conditions. So, Lakira, do you want to tell us about your experience and meeting Michelle?
Well, unfortunately, we met Michelle through a SMA diagnosis. Our paediatrician basically told us that this is your child. He has spinal muscular atrophy. Go home and plan his funeral because he will not survive past 9 months. But you can go and see this woman, Michelle, at Sydney Children's Hospital. So called her. Michelle will tell you to this day, she still remembers me sobbing on the phone saying, please don't let my child die. The next day we drove to Sydney and Michelle held this tiny little baby in her hand that he flopped in her arm. And she said, yes, he has spinal muscular atrophy. But we can help you. We have this drug that we're trialling. It's not a cure, there's no guarantee, but let's try. 9 years later, we have Kalani. A normal 9, yes, he still has SMA, and there's still symptoms of that, but he lives such a fulfilling life, and none of that would be possible without the research, which, you're forever grateful for that.
And so I hear that he also is very popular and drives the philanthropy division of the Children's Hospital as well.
Oh yes, Kalani's been well known the last 8 weeks on level 8. So Kalani's just had spinal surgery to put rods in his back for scoliosis, a common symptom of SMA due to the muscle weakness. But he is the cheekiest, loving boy that you'll ever meet. Loves the Bulldogs, the biggest Bulldogs fan you'll ever meet. But there's nothing Kalani can't do. He is so determined. It makes you as a parent extremely proud.
And so, Michelle, you also, in addition to introducing newborn screening around Australia, which is like right at the crest of world interventions, you also discussed and introduced Mackenzie's mission with the Federal Health Minister. Do you want to give us a bit of background to that?
I think it's that every time I talk to a family, they teach me something and you think you have the answers and then they ask another question and you think, oh, there's more work to do. And so when we are diagnosing families, particularly through newborn screening, they're saying, why are you telling us now? Why weren't you telling us before we planned the pregnancy? I thought, well, that's a really good question. And one of the families that I diagnosed early on, Mackenzie was the baby's name, and her parents asked me that question, and they were inspiring, and they said, we need to change this. And so we actually worked together as a partnership, and it was a real campaign. It was where everyone would listen, we would talk. So we went and met Brad Hazard, we went down to Canberra and met Greg Hunt together. We talked to geneticists and we wrote lots and lots of letters, particularly they did. And by the time we got a meeting with Greg Hunt, she was not treated, this child. Mackenzie was no longer with us. But her parents wanted her legacy. And so he said, actually, that's a really good question. I think we do need to change this. And he funded a $20 million research program looking at how genetic testing could be offered to prospective parents to help them plan reproductive choices that align with what they want to do. So I think it was having that story and that connection and that face that really supercharged that mission. And that research was undertaken nationally with a large group of people offering carrier testing for over 600 severe genetic conditions to 10,000 couples. And so it was about, well, how can we do this? And the government was amazing. They said, you can't just do it in the cities, you have to do it everywhere. This has to be equitable. So there was recruitment in every state, in every town, well, not every town, but, really strategically going to rural, remote, Indigenous areas as well. And so I think the evidence is that it was identifying conditions and it is enabling reproductive choice. And I think it's currently under consideration for addition to the medical benefits schedule so that it can be equitably accessed. But the most common conditions, spinal muscular atrophy, cystic fibrosis, and Fragile X syndrome, are already available. So those three are now, and they weren't before, on a Medicare benefits item. So you can go to your GP, you can say, I'm planning a baby, is there anything I need to know? You can get your Medicare card out and have those three tested. And if there's a risk, then you can make a decision about how you want to plan your pregnancy and the birth of your baby. And I think that is very powerful, that there's not many countries in the world where that's available.
So, Akira, we have all of our NeuRA supporters here and some scientists and budding neuroscientists. What message would you have to the community, to the supporters and researchers?
My message would be that without your support, dedication to help provide people like Michelle the funding to be able to research this, children like Kalani and future generations, they wouldn't have a chance to experience life or anything like that. Like, everyone has a right to enjoy life, achieve milestones, and just be a part of a family. We all have family members that it could affect, and you never know when it will happen to you as well. So I think it's very important that, we all jump on board. We, as a community, band together and make a difference.
Thank you, guys. That was very powerful. I'd like to ask if there's any questions from the floor. Rather cheekily, I'm going to ask one, if that's okay. Michelle, you mentioned the incredible number of conditions that you have to treat. How does something like childhood dementia compare in terms of numbers with, say, childhood cancer?
So I think those two words don't belong together, but we see it, children and dementia. And again, that came from families articulating that, and it really made me stop and think. So there are children with neurodegenerative diseases where I see they're confused, they're wandering, they're irritable, they're agitated, they can't remember, they forget how to communicate, they're going backwards. I've just described dementia in the ageing. And I went, oh my goodness. And what we had considered is them individually, one disease at a time. And the families were walking on parallel streets and never being connected, and there was never a collective approach on how to support them or treat them, yet the experiences were the same. So they came up with the term childhood dementia, and it's to have a collective response and to really energise that. And that's been coined in Australia, and there's now a global movement where Australia is leading the charge to adopt this term, and it's what parents want because it recognises what the children need. And Australia is the very first country in the world to recognise children as part of their national action plan. And I think, speaking to your question and the need, it affects about 1 in 1,200 children. Now, childhood cancer, the survival is probably 95%. Children with dementia, 5% have effective therapies. It's completely the opposite. And part of that is that in childhood cancer, it's been amazing. It's been iterative over 50, 60 years, where every step forward there's a new advancement. They started at 30% survival in the basements of hospitals with mustard therapy, but now it's amazing, and you can get the biopsy, they'll sequence it, and there'll be a new therapy made for just that child. 5% with childhood dementia, it hasn't moved. So that's where the inequity is. And the consequence of that is that the number of deaths in Australia for children with cancer is the same as the number of deaths for children with dementia. It really reflects the underinvestment in research and the under-recognition of these children. And so I think the fact that we're now using this term and it's gathering momentum means that we will be able to do better and have a greater impact for more people.
Thank you. Any questions from the floor? If you'd like to raise your hand, I'll bring the mic over.
My question is just, I guess, about the screening that you mentioned. How successful is screening in terms of reducing these conditions, to zero eventually, or, is there still a random chance, occurrences of these conditions as well?
So screening is not a diagnostic test. It gives you a risk, and you're either at high risk or low risk. You're never at no risk, okay? And I think the reason for that is that you can have new changes in your genes between parents and children, and you can't detect that by testing the parents. So that's why understanding what is being offered and what the result means is really important. So we've experienced that in our clinic where we've had parents who've had carrier screening, and then I call them and say, your newborn screen test is positive, and they go, you're wrong. I say, I don't think so, please come and talk to us, it's really important. And it's when you have these conversations that you realise there's a whole health literacy piece and education piece that has to happen with the rollout of technology as well. But I think in terms of SMA, it's probably going to detect 95% of people. So that's pretty impactful and meaningful. And there's private tests that people can pay for to test for a broader range of conditions at the moment, and I think that's probably accessed more in the eastern suburbs than other parts of Australia, and that equity piece is going to be really important, which is why we need research for evidence to change that into a public health system if that's the right thing to do.
Any more questions?
Bit of a different one, I think. One of our granddaughters has been diagnosed with ADHD, and just in conversation with friends and things, people are saying, that seems to be becoming more and more common, and I'm just wondering if research has been done into it as to whether it's neurological or environmental, and where's it going?
It's a good question and very complex. I think we have to take a biopsychosocial approach, and what that means is you look at the biology. Is there something that's changing the brain as it's forming, like, I don't know, but nanoplastics? It's very topical. But then what's happening in society with the impact of social media and the environment, and then, what's happening in the home in terms of play and interaction. And so I think with a lot of the conditions, not just ADHD, but children with neurological diseases, they're at risk for what we call comorbidities or second issues with the brain, and that can be ADHD or it can be autism. So often you don't just have one, you carry and you pick up a few others. So I think where I come from, which aligns with the NeuRA's theme, is prevention, and we recognise that it's not just the biology of the brain, it's the environment, and part of this is creating a rich environment for the child. So if you're born with prematurity, you go into an early intervention clinic and surveillance. And so how we're approaching this is that children are at risk with one brain disorder of others. So we need to teach parents that this behaviour may actually be them adapting and trying to express themselves. If they can't express themselves because they can't move their mouth to talk, it doesn't mean it's maladaptive or bad. It could be a different signal. We want to teach parents to recognise that, to respond to it and nurture it and create a loop of feedback so we don't get these negative behaviours of ADHD or autism that are perceived negatively. We want to strengthen them, look at capacity and really enrich environments. So I guess my research takes it from that lens rather than looking at causes. It's about what interventions and preventions can modify that. And so, for people like Kalani that were born with SMA before we had newborn screening who do have weakness, you could do a cognitive assessment and say, he can't do this because he can't move. So we need to, but you hear what like Kira says, he can do it. Our assessments might be wrong, and we actually need new assessment tools to be able to measure brain function in children with disability that isn't underestimating it, and then creating a negative lens for what they can do. We need to be creating positive lens, strengthening and enriching to really promote their capacity, because they can do so much more than what people estimate.
And it's just one, on a linked discussion, so one of our other NeuroQuest recruits is Emma Devaney, and she's been looking at patients and families with neurodegenerative diseases, so dementia, frontotemporal dementia, and motor neuron disease. And she interviewed 2,000 family members and found a much higher incidence in the families of autism spectrum disease, schizophrenia, bipolar disease. And so we're seeing now that there's an overlap between what we would say is brain conditions and mind conditions. And that's probably also suggesting now as well shared mechanisms. And then perhaps some of the treatments that are being very successful, like monoclonal antibodies, inflammatory treatments, might be useful for schizophrenia, autism. And that's what we hope to do through large-scale programs through NeuRA.
Like Kira, actually, there's one thing I just wanted to ask you. You talk about Kalani and all the things he does. Is it true he was playing football this afternoon?
Yeah, over at Bear Cottage, he was out in the car park with the nurses playing football. Despite everything that he goes through, he can hit a cricket ball, kick a soccer ball. He's even learned how to kick a football off a tee on the foot of his wheelchair. Like, there's nothing that he can't do, and he's determined. The more you tell him no, the harder he's going to try.
How often do you try and tell him no then?
Not often, it's a losing battle. As Michelle would know.
I just found out that he can call our team through his Apple iWatch and talk to us. And like last week I was in his room and he called Captain Freckles, who's part of Starlight, to tell them to change the movie because it was too scary for the kids in the hospital.